This video is on prenatal hormones and changes that occur to the mother and then postnatal development. We'll start with the maternal changes and the placental hormones. So placental hormones are going to play a role in maintaining the pregnancy as well as helping the fetus to grow and also for breast maturation throughout pregnancy and breastfeeding. As the pregnancy progresses, the uterus will expand into the abdominal cavity and the placenta starts to act as an endocrine organ. The syncytioblast starts to make and release hormones into the maternal bloodstream. The syncytiotrophoblast synthesizes human chorionic gonadotropin, or HCG, human placental lactogen, or HPL, the placental prolactin, relaxin, and progesterone and estrogens. Let's talk about human chorionic gonadotropin. So HCG is produced by the chorion. It appears in the maternal bloodstream soon after implantation. The presence of HCG in the blood or in the urine samples of the mother is a reliable indication that a pregnancy has occurred. Home pregnancy tests detect the presence of HCG in the urine. HCG resembles luteinizing hormone, or LH. It maintains the corpus luteum and the secretion of progesterone from the corpus luteum to keep the endometrial lining functional. HCG also prevents menstruation. Without HCG, the pregnancy ends because then the endometrium would be shed off since progesterone levels would fall. With HCG, the corpus luteum persists for 3 to 4 months before gradually decreasing in size and secretions. Human placental lactogen is another hormone that's produced by the syncytiotrophoblast. HPL prepares the mammary glands for milk production. It's similar to growth hormone. It ensures that glucose and protein are available for the fetus to grow. Human placental lactogen is released from the placenta and it goes into the maternal blood. Once in the maternal blood, it travels to the mammary glands, and in the mammary glands, HPL will be converted to placental prolactin. The placental prolactin plus the prolactin from the mother's anterior lobe of the pituitary gland will both facilitate milk production, which will supply the fetus with the nutrients it needs to produce its own energy. Relaxin is the hormone that increases the flexibility of the pubic symphysis to permit the pelvis to expand during delivery. It causes the cervix to dilate for delivery, and it suppresses the release of oxytocin, which will delay the onset of labor. Then we have progesterone and estrogens. After the first trimester, the placenta produces enough progesterone to maintain the endometrial lining and to continue the pregnancy. Near the end of the third trimester, estrogen production accelerates to stimulate labor and delivery. Maternal systems have to provide for the fetus at the same time they are performing normal operations for the mother. As the demands of the fetus increase, the demands on the maternal systems also increase. The mother must breathe, eat, and excrete now for 2. The major changes include the following. First of all, maternal respiratory rate and tidal volume increase. The mother's lungs deliver the required extra oxygen to the fetus and remove generated carbon dioxide. So the respiratory rate and volume need to increase to do this. Second, the maternal blood volume increases. This is due to the increased blood flow into the placenta. Since mother is giving up her oxygen for the fetus and is taking on increased carbon dioxide from the fetus, this will lead to the mother producing additional renin and erythropoietin. The synthesis of renin and erythropoietin will increase the blood volume and the red blood cell production. Third, the requirements for nutrients in the mother increase by 10 to 30%. So what we'll see in the mother is that she will have an increased appetite. 4, the maternal glomerular filtration rate increases by approximately 50%. This corresponds to the increase in blood volume from the renin and the erythropoietin. The increased glomerular filtration rate accelerates the excretion of the metabolic wastes that are generated by the fetus. So the mother is able to get rid of the wastes generated by the fetus by having an increased glomerular filtration rate. Pregnant women need to urinate frequently because the volume of urine production increases, and the weight of the uterus on the urinary bladder causes her to have the urge to urinate. The mother also has changes in her reproductive system. Her uterus increases in size from 3 inches to 12 inches, and from 1 to 1.25 ounces to 2.5 pounds. The cells of the uterus hypertrophy, especially the smooth muscle fibers. The uterus may contain 2 liters of fluid plus the fetus and the placenta for a total weight of 12 to 15.4 pounds. At full term, the uterus pushes the maternal abdominal organs out of their normal positions. The mammary glands increase in size. Secretory activity in the mammary glands begins. This secretory activity requires HPL, or human placental lactogen, as well as placental prolactin, as well as prolactin from the mother. It also requires estrogens, progesterone, growth hormone, and thyroxine. By the end of the 6th month, the mammary glands are fully developed and they produce clear secretions stored in the duct system. The milk at this time, by the end of the 6th month, can be expressed from the mammary glands. An abortion is the termination of a pregnancy. Spontaneous abortions, otherwise known as miscarriages, result from developmental problems like chromosomal defects in the embryo, or hormonal problems like low luteinizing hormone or low levels of progesterone or even insufficient human chorionic gonadotropin. Therapeutic abortions are performed when the continued pregnancy poses a threat to the life of the mother. Then there's induced abortions, and these are elective at the mother's request. Childbirth, otherwise known as parturition, is the forcible expulsion of the fetus from the uterus through the cervix and the vagina. There's tremendous stretching of the uterus towards the end of the pregnancy that causes a gradual increase in the rate of spontaneous smooth muscle contractions in the myometrium, or the muscle layer of the uterus. In the early stages of labor, the contractions are weak, painless, and brief. Progesterone is released by the placenta, and this is inhibiting the contractions from getting too strong. Late in the pregnancy, some women experience occasional spasms in the myometrium, but these are not regular or persistent, and these are called Braxton-Hicks contractions or false labor. True labor begins when the fetal pituitary gland secretes oxytocin. This is released into the maternal bloodstream at the placenta and will increase the contractions of the myometrium as well as prostaglandin production. When the contractions begin in the myometrium, there's a positive feedback that ensures they will continue until delivery has been completed. Each contraction begins near the superior portion of the uterus and sweeps in a wave toward the cervix. They are strong and at regular intervals. As parturition approaches, the contractions increase in force and frequency, changing the position of the fetus and moving it towards the cervical canal. Labor has 3 stages: the dilation stage, the expulsion stage, and the placental stage. So I'm going to start by talking about the dilation stage. The dilation stage begins with the onset of true labor. During this stage, the cervix dilates and the fetus shifts toward the cervical canal, moved by both gravity and uterine contractions. The contractions during this stage last up to 30 seconds and are 10 to 30 minutes apart. Late in this stage, the amniochorionic membrane ruptures and fluid is expelled. At this point, we say that her water has broken. If it occurs too early, the fetus may be at risk from infection. The dilation stage typically lasts 8 or more hours. The expulsion stage is the next stage. It begins as the cervix is pushed open by the fetus when dilation of the cervix reaches 10 centimeters. Contractions in this stage last a full minute and are 2 to 3 minutes apart. Expulsion continues until the fetus has emerged from the vagina. This typically lasts less than 2 hours. The arrival of the newborn is called delivery. If the vaginal canal is too small, the clinician might perform an episiotomy, which is an incision through the perineal musculature. This is repaired with sutures. It's simpler to suture a straight line from an incision than it is a jagged line from tearing. Immediately after birth, the newborn's health is assessed. The heart rate, breathing rate, skin color, muscle tone, and reflex responses are all assessed. This is called the APGAR score. Each criterion is scored from 0 to 2. A score of 8 to 10 indicates a healthy baby. Next is the placental stage. In this stage, the partially empty uterus builds muscle tension. The muscle contractions tear the connections between the endometrium and the placenta. Within an hour of delivery, the placenta is ejected. The placenta is called the afterbirth. The placental stage is accompanied by a loss of blood, but uterine contractions usually compress the blood vessels of the uterus to restrict the blood loss. Blood loss is usually tolerated without difficulty. Some common complications of labor and delivery include the umbilical cord might have looped around the baby's neck, or the baby might have an abnormal fetal heart rate. The heart rate should normally be between 110 and 160 beats per minute. Stalled labor is another common complication. Premature labor is also common, and difficult deliveries might also occur. Premature labor occurs when true labor begins before the fetus has completed normal development. The chances of survival are related directly to body weight at delivery. In many hospitals, 24 weeks is the cutoff point for when doctors will use intensive medical intervention to attempt to save the life of a baby born prematurely. In the hands of experienced specialists, babies born slightly earlier may have a chance at survival. Babies born at 23 weeks may survive in a state-of-the-art NICU, but the odds of survival are much lower. The odds of survival increase as the pregnancy progresses, and even an extra week in the womb can make a difference. In general, premature babies born closer to 37 weeks will be better off than those born before 28 weeks. The fetus should rotate in the uterus for delivery head first, facing the mother's sacrum. Any other presentations could produce a difficult delivery. 6% of fetuses face the mother's pubis. In these cases, the delivery takes more time. The risks to the infant and mother are reduced if forceps are used for the delivery. 3 to 4% of fetuses have their legs or buttocks enter the vaginal canal first. This is called a breech birth. The risks to the fetus in this presentation are higher. The umbilical cord may become constricted, cutting off placental blood flow. The cervix may only dilate to fit the legs and body, but not the head. This compresses the umbilical cord and prolongs delivery, and subjects the fetus to severe distress and potential injury. A C-section or cesarean section might be needed in this case. Multiple births can take place due to fertility drugs or assisted reproductive technology, or in older women who release more than one oocyte in a cycle, or even just because of genetics. Twin births in the U.S. occur in 33.7 out of 1,000 deliveries. Fraternal twins, otherwise known as dizygotic twins, develop when two separate oocytes are ovulated and fertilized. These twins won't be identical due to the crossing over in meiosis. The chances of them being identical are 1 in 8.4 million. So they will have their own unique genetic presentation. Identical twins, known as monozygotic twins, result from either the separation of the blastomeres early in cleavage or from the splitting of the inner cell mass during gastrulation. The genetic makeup in identical twins is identical because both are formed from the same pair of genes. Triplets, quadruplets, and larger multiples result from multiple ovulations or from the blastomeres splitting or a combination of the two. Taking fertility drugs stimulates the maturation of abnormally high numbers of follicles, and this increases the incidence of multiple births. Multiple fetuses multiply the strain on the mother. Premature labor chances are increased. Risks to the mother and fetuses are greater. Risks to the newborn are increased due to lower birth rate, and problems in delivery as one or both of the fetuses enter the vaginal canal in an abnormal position. Cojoined twins may develop if splitting of the blastomeres is not complete. Once the baby is born, the baby enters postnatal development. Postnatal development typically includes 5 life stages: the neonatal period, infancy, childhood, adolescence, maturity. At maturity, the development ends and the process of aging or senescence begins, ultimately leading to death. Transitions between the stages are gradual and the boundaries are indistinct. The characteristics and abilities, though, are distinct. The neonatal stage is the time from birth to 1 month. Infancy or babyhood is 1 month to 1 year, and childhood is 1 year to adolescence or to puberty. During these stages, the organ systems become fully operational and have characteristics of adult structures, and individual growth is rapid with body proportions changing significantly. Pediatrics is the medical specialty that focuses on postnatal development from infancy through adolescence. During the neonatal phase, which is the first month, the newborn has to adjust to life outside the womb. The fetus becomes the neonate. At birth, the lungs of the neonate are collapsed and they're filled with fluid. The baby's first breath, which is a massive and powerful inhalation, will fill the lungs with air. When the lungs expand, the ductus arteriosus closes. The ductus arteriosus is the connection between the pulmonary trunk and the aorta. The foraminal valley also closes. This is the hole between the right and the left atrium. The neonatal heart rate decreases from the fetal heart rate. The average 150 beats per minute of the fetus changes to 120 to 140 beats per minute. Before birth, the digestive system is inactive, but it is accumulating bile, mucus, and epithelial cells. This mixture is called the meconium. The meconium is excreted during the first few days as the newborn begins to nurse, and the digestive system becomes active. The kidneys excrete wastes, and glomerular filtration is normal in the neonate, but the kidneys can't concentrate urine very well, so urinary water losses are great and the neonate has greater fluid requirements than adults and has an increased risk of becoming dehydrated. Also, the neonate has little ability to control its body temperature, especially in the first few days. Subcutaneous fat is deposited and the metabolic rate increases to warm the infant as it grows larger. The neonates, though, lose heat very quickly. To maintain the body temperature, their metabolic rates must be very high, like twice that of adults. And lastly, the newborn is dependent on nutrients that are contained in the breast milk. The newborn is unable to fend for itself to get the nutrients that it requires. The mammary glands secrete colostrum in the mother by the end of the 6th month of gestation. Colostrum contains more proteins and less fat than breast milk. It also contains antibodies, and it contains mucins that can inhibit the viruses. This prevents gastroenteritis and diarrhea in the infant. After 2 to 3 days, colostrum won't be secreted, and instead the mammary glands will secrete milk. Breast milk contains water, proteins, amino acids, lipids, sugars, salts, and lysosome, which has an antibiotic property. The milk production is maintained through hormones such as prolactin and oxytocin. Milk ejection is a reflex that allows the milk to be available to the infant. The reflex continues for 1 to 2 years after the birth. When the infant is weaned, the reflex stops and then milk production stops. Soy-based formulas lack antibodies and lysozyme. Early weaning is associated with an increased risk of infections and allergies in the infant. Growth during infancy and childhood occur under the direction of growth hormone, adrenal steroids, and thyroid hormones. These hormones affect different tissues and organs in specific ways so that growth doesn't occur uniformly. Body proportions gradually change. For example, the head is large at birth, but then it decreases in proportion to the rest of the body as the child grows. Adolescence begins at puberty. The hypothalamus secretes gonadotropic releasing hormone, which makes the anterior pituitary release follicle-stimulating hormone and luteinizing hormone. The ovaries and the testes of the male and female child are sensitive to FSH and LH. Puberty generally starts at age 12 in boys and 11 in girls. Changes in adolescence include changes in the integumentary system. For instance, testosterone stimulates the terminal hairs on the face and the chest of the males, so they get hair on their face and hair on their chest. In females, estrogen causes the follicles to produce fine hairs instead of terminal hairs. Both estrogen and testosterone stimulate terminal hair in the axillary and the genital areas. Sebaceous gland secretions are stimulated and may cause acne. Adipose tissue responds differently to estrogens and testosterone. Estrogen causes fat deposition in breasts, and the mammary glands develop in the females where they don't develop in the male. In the skeletal system, both testosterone and estrogen accelerate bone deposition and skeletal growth. Testosterone and estrogen promote the closure of the epiphyseal cartilages and put limits in the height of the child. Estrogens cause more rapid closure and earlier closure, so girls are typically not as tall as boys. Girls grow more rapidly between the ages of 10 and 13, whereas boys will grow more rapidly between the ages of 12 and 15. In the muscular system, the sex hormones stimulate skeletal muscle fiber growth, increasing the strength and endurance of skeletal muscles. The effects of testosterone greatly exceeds the effects of estrogen. This accounts for the differences in body mass, even if the male and the female are the same height. In the nervous system, estrogens and testosterone affect central nervous system centers concerned with sexual drive and sexual behaviors. Males and females will have very different sexual drives and sexual behaviors. In the cardiovascular system, testosterone stimulates erythropoiesis. This increases the blood volume and the hematocrit, so males have more blood volume than females. Also, females lose iron during menstruation. This may lead to an iron deficiency anemia. Late in the uterine cycle, estrogens and progesterone promote water movement from the plasma into the interstitial fluid, leading to an increase in tissue water content, which causes them to feel bloated. Estrogens decrease plasma cholesterol levels and slow the formation of plaque, so females have a lower risk of atherosclerosis than men. In the male reproductive system, testosterone stimulates the development of the prostate and seminal glands and stimulates spermatogenesis. In the female, the estrogens target the uterus. It thickens the myometrium, it increases blood flow to the endometrium, and it stimulates the cervical mucus production. It also promotes the functional development of accessory reproductive organs. Ovulation may or may not occur in the first few cycles that a girl has, but after this initial stage, the female is fertile, even though she will still grow and mature. After puberty, the background secretion of estrogens or androgens, like testosterone, maintains sex-specific differences. Growth continues at a slower rate until the age of 18 to 21. By then, the growth plates have closed and the child will stop growing in height. Adolescence is over when growth stops. This usually occurs in the late teens or early 20s. At this point, the young adult is considered physically mature. These sex hormone levels decline at menopause in the female and during andropause in the male, which is also called the male climacteric. Senescence is the term used for the process of changes that occur after maturity. Functional capabilities of the person are reduced, and the changes ultimately lead to death. The changes in senescence include loss of elasticity in the skin, causing sagging and wrinkling, a decline in bone deposition, which leads to weak bones and degenerative changes, making the person less mobile, reductions in muscular strength and ability, impaired coordination, memory, and intellectual function, the reductions in circulating hormones or a reduction in sensitivity to those hormones. Cardiovascular problems start to appear, or there might be a reduction in peripheral blood flow. There's a reduced sensitivity and responsiveness of the immune system, which leads to infections, cancer, or both in some. The reduced elasticity in the lungs, which lead to decreased respiratory function. Decreased peristalsis and muscle tone occur in the digestive tract, leading to constipation. Decreased peristalsis and muscle tone in the urinary system occur. A reduced glomerular filtration rate might occur. And the reproductive system at menopause or at the male climacteric becomes inactive. Geriatrics is the name given to the medical specialty with the aging population. Death occurs when the body's existing homeostatic mechanisms can't counter some of the combination of the stresses that occur on the body. All right, this ends our second video on development. Our next two videos, we will talk about inheritance and genetics. We'll see you next time.